Welcome back. This episode is brought to you by Clinician Assist. Right now, roughly 1 in 8 young adults is turning to chatbots for mental health advice. OpenAI reports that over 1 million people a week tell ChatGPT they are thinking about suicide. Companies are moving quickly to capture this demand, marketing applications like Therabot and Therapist GPT. These systems currently operate in a legal gray area, advertising automated support directly to vulnerable demographics, including teenagers, without traditional medical oversight. California is now attempting to draw a hard line. Senate Bill 903 currently sits in a Sacramento suspense file, the holding room for legislation with a significant price tag. If it passes, it is poised to become the national template for how artificial intelligence can be used in clinical care. The legislation is specific about what software cannot do on its own. It forbids AI from writing a diagnosis, creating a treatment plan, judging how urgently someone needs help, or acting as a client's actual therapy. Lawmakers designed the bill as a strict bottleneck to stop autonomous AI therapy. However, the bill provides 2 specific legal pathways that allow a machine to hold a two-way conversation with a client. One path requires a licensed human therapist to review and approve every exchange the AI has with a patient. The other allows the machine to speak if the FDA has cleared that specific product for that specific job. California has mandated that conversational AI must fit into one of these 2 categories to be legal. But writing a standard into law is different from applying it, and we have to look at whether either of these pathways is actually functional today. Looking at the federal record, the FDA has cleared more than 1,200 medical devices that use artificial intelligence. Not one of them is approved as a conversational tool for mental health. In fact, the agency has only ever cleared one talking AI product. That happened on December 23, 2025. This product, called UpDoc, is an application for managing type 2 diabetes. It works by carrying out a medication plan a human doctor has already written, providing patients with instructions from that plan. UpDoc secured clearance by using a comparison track, pointing to a 6-year-old product already on the market, and proving the software was similar enough, even though the older device couldn't hold a conversation at all. Last November, the FDA's digital health advisors spent a day discussing AI that talks to people about their mental health. They realized they have no specific framework for evaluating these products, and kept returning to the same solution: human escalation. This means California's legislative exception points toward a federal standard that does not yet exist. Until the FDA writes rules for mental health chatbots, every developer will be forced toward the alternative, the licensed human reviewer. Under this requirement, the licensed therapist in the chair must review and approve the AI's work, taking ultimate responsibility for everything said to the client. This is the human-in-the-loop safeguard. It is the load-bearing control written into corporate AI policies and state laws alike, resting on the idea that a qualified human will catch a machine's mistakes. Almost nobody has checked whether that works. The closest public measurement comes from a developer in Belgium who built a browser game where players have 60 seconds to approve or deny the commands of an AI coding agent. Across 409,000 commands, reviewers missed roughly a third of the dangerous requests. They waved through scope violations, commands where the AI reached for credentials it shouldn't touch, 35% of the time. Real-world telemetry suggests the reflex is even stronger. Anthropic data shows that users approve roughly 93% of permission prompts overall. Most are routine, but the figure describes a habit of clicking yes regardless of the risk. The mechanism behind this is well understood. High alert volume and a lack of context lead to fatigue. When every prompt seems routine, a human reviewer eventually stops analyzing and starts rubber stamping. This leaves California's primary safety mechanism for AI therapy dependent on a human reflex that has been empirically proven to fail under pressure. California is implementing these rules today, while the FDA remains in the early stages of building a framework for artificial intelligence. Tech trade groups are fighting the bill, arguing that requiring a clinician sign-off for every interaction creates a massive bottleneck that will slow down patient access to care. For software builders, the bill changes the design requirements. Systems must now be built to support a professional's review workflow rather than acting as autonomous tools for the patient. The largest shift, however, is one of liability. By making the licensed professional the operative safeguard, the bill ensures that clinicians remain responsible for what the software produces. Malpractice and licensing risks stay with the person in the chair. California is drafting a national template against a federal standard that does not exist, leaving patient safety entirely to a human approval process that has never been measured in a clinical setting.